Welcome everyone to today's presentation. Our speaker today is Joy Alonzo. This is the fourth presentation in the virtual Community Opioid Symposium. This free educational event is brought to you by the Louisiana Department of Health Office of Behavioral Health, Acadiana Area Human Services District, and Women's Foundation. The purpose of the Community Opioid Symposium is to increase awareness and education for the prevention and treatment of opioid use, misuse, and abuse. For information on future presentations in this series, visit womensfoundation.com/COS. This session is accredited for 1.5 hours for the following: social workers general credit, addiction specialist, AMA, PRA Category 1 credits. It is pending approval for licensed professional counselors. Full participation is required to receive credit and will be monitored throughout the session. After the event, you will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Joy Alonzo has no financial disclosures. None of the members of the Symposium's Planning Committee has any financial disclosures. Joy Alonzo is a clinical assistant professor in the Department of Pharmacy Practice at the Texas A&M College of Pharmacy. Additionally, she is the ambulatory care pharmacy director for Health for All Clinic in Bryan, Texas. One of her current clinical assignments is director of clinical programs at Spring Outreach Services in Spring, Texas. In this role, Dr. Alonzo provides support, resources, and patient-centered interventions to youth and adolescents and their families with mental and behavioral health challenges, including substance use disorder. She is a nationally certified instructor in adult and youth mental health first aid, and via Spring Outreach Services, she provides mental health first aid certification classes to students and community members. Dr. Alonzo has deep clinical experience, including provision of specialized pharmacotherapy for varied patient populations, including primary care, psychiatric pharmacotherapy services and counseling, pediatrics, geriatrics, diabetes education and management, targeted disease state management, ambulatory surgical care, ambulatory anticoagulation, infectious disease, and critical care. Dr. Alonzo has specialized training in mental and behavioral health advocacy, policy, and community outreach, as well as in the evaluation and oversight of psychotropic medication utilization in vulnerable populations. Dr. Alonzo received her Bachelor's of Science in Pharmacy from the University of Pittsburgh, Master's of Engineering in Engineering Science from the Pennsylvania State University, and a doctoral degree in pharmacy from Howard University College of Pharmacy. Please welcome Dr. Joy Alonzo.
Howdy, as we say in Aggie land. So I'm thrilled to be here this morning to talk to you about opioid overdose education, harm reduction, and naloxone administration. I am also, Texas A&M started when the president declared the opioid crisis a national public health emergency. Texas A&M initiated what is called the Opioid Task Force at the university level. And I am the co-chair of the Opioid Task Force, along with Dr. Marsha Ori from the School of Public Health. So as part of our mission for the Opioid Task Force, Texas A&M, the Health Science Center, actually became the first health science center in the United States where all health science center students are provided the education that you're going to see right here, and they're also issued their own naloxone rescue kits. That's about 5,000 students system-wide. So that would be every College of Nursing, every College of Pharmacy, every College of Medicine, College of Dentistry, and School of Public Health student that comes to study at Texas A&M. So our kind of look at it was one of the ways we can influence the trajectory of the opioid crisis is to actually develop a new kind of clinician. So we actually developed this strategy to breed a different type of clinician that looked with better eyes, different eyes, and to teach them the foundational principles of screening for and treatment and support of patients that are at risk or currently are affected by substance use disorder. So let's get started. So here's some of the learning objectives. I'm not going to read through those. This presentation is going to be actually provided to you, so you have access to this. And please do contact me. I have my contact information in here if you have any questions or would like further information. The Narcan kits that we have, and actually I'm going to send them to the Women's Foundation, so that if you have an opportunity, that you'll be able to get your own kit from the Women's Foundation. And that they're provided through the Texas Targeted Opioid Response Grant, the TTOR grant. But we're willing to share. I'm partnered with the UT San Antonio School of Nursing and Texas A&M UT Operation Naloxone and Dr. Lucas Hill. So what is an opioid? That is the question of the hour, right? And how do you know what's an opioid and what's an opiate? Well, here it is. You don't have to know. Opiate is actually an older term, and that really refers to the medications that are directly derived from the opium poppy. And opioid was a term that was actually coined to embrace all the synthetic products that were derived from opiates. So fentanyl is an example of a synthetic, and morphine is an example of a medication that's directly derived from the opium poppy. But guess what? They're all opioids. So while morphine is an opiate and fentanyl is not, they're all opioids. So if you just call everything an opioid, you're good. So here's morphine. And here's the chemical structure, and this is again derived directly from opium, which is harvested from the opium poppy. And here we have diacetylmorphine. Are you guys able to answer? If I ask you a question, are you able to answer me through the chat or some way like that? Amy, can they answer?
Yes, they'll be able to type in the chat.
Oh, okay, so great. So what's diacetylmorphine? What's the trade name for diacetylmorphine? Does anyone know? Have you ever heard of that, diacetylmorphine?
And I'm keeping an eye on the chat, and I don't see anybody answering just yet.
Okay.
Oh, I've got some question marks.
Okay.
Maybe nobody knows.
Okay, so diacetyl.
Somebody's guessing heroin?
Yes.
Diacetylmorphine
is heroin. Heroin is the trade name, just like Tylenol is the trade name for acetaminophen, right? Heroin is the trade name for diacetylmorphine. And heroin was invented by the Bayer Aspirin Corporation. Yes, the very one that produces baby aspirin, the Bayer Aspirin Corporation. They invented heroin as a treatment for morphine. And during back in the Civil War and into World War I, the turn of the century there, between the 1800s and the early 1900s, morphine was used extensively in battle wound management. So actually a whole lot of soldiers came home and they had an addiction to morphine. They had been medically managed with morphine and developed an addiction to morphine. And so actually heroin, look at the root of this, hero. This was actually invented as a treatment for morphine addiction, if you can believe that. It wasn't until years later we figured out that the addictive properties of heroin are, much, much higher than even morphine itself. And I collect up these occupational hazard of a professor who's interested in substance use disorder. I collect up these old ads, and you can see December 1901. cheapest, specific for the relief of coughs, using heroin for cough medicine. And I have pictures of it being given to children, you know, for teething and for, you know, encouraging sleep in your child. Yeah, the kind of sleep they never wake up from, right? Who can tell me, too, what president said this? Addiction to morphine is the biggest problem we have in the United States today. Can anybody put that in the chat? And it wasn't President Trump, let me tell you that.
I don't see any. Oh, Bush.
Further back.
Carter.
Further back than that.
Alcohol. Somebody's saying alcohol.
No, it was specifically, the statement is that addiction to morphine is the biggest problem that we have in the United States today.
Lincoln?
Yes, it was President Lincoln. That's exactly right. It was President Lincoln. That's right. So it's this problem associated with opioids goes way back. And here, this lithograph is of an opium den, you know, in China, probably, you know, at least 1,000 years ago. So here's some common opioids with medical use. These are all very, very common in circulation right now. So there's codeine, which is also a precursor for morphine. In the body, codeine turns into morphine, and that's Tylenol number 3 and number 4. There's morphine, of course, which is MS-Contin and Cadian. These are all the trade names for brands of morphine. Here's hydrocodone. Do I have any House watchers? Dr. House. So this was Dr. House's actually substance of choice was hydrocodone. And here's all the trade names for products that contain hydrocodone, which include Vicodin, Lortab, Norco, Hycodan. All those are very, very common. Here's oxycodone, which is OxyContin, and Percodan and Percocet. Oxymorphone, which is Opana, which was actually developed to be a tamper-resistant formulation. It was supposed to discourage misuse. Hydromorphone is dilaudid, probably not as popular as it was maybe at the turn, you know, around in the early 1900s, but still available. Meperidine is Demerol. And here's the fentanyl products, and these are all medical fentanyl, not the kind of fentanyl that people overdose on typically in the community. So these are the medical uses for fentanyl are very common in deep bone pain and very severe post-surgical pain, and then in oncology, people that are going through cancer treatment. This is very, very common, these products. Here's sufentanil. That's actually a relatively new product, that Desuvia, that has limited distribution in the military. It was actually designed, so if you were injured with an incendiary device, that you would actually be treated with this because you can't get IV access. So this is something that's sublingual that gives actually the same kind of pain management that an IV does. Buprenorphine, this is confusing. This is a partial opioid, Suboxone, and this is actually used for treatment of opioid use disorder, buprenorphine. Tramadol, this is the one I get pushback on from clinicians. They say like it's not an opioid. It surely is, and it's a controlled substance too. So it is an opioid, but again, it's a partial opioid. It's not a full opioid. What's another one? Oh, loperamide. Can anybody put in the chat what loperamide is used for? Or Imodium? What's loperamide used for?
Diarrhea.
Yes, exactly. So loperamide is an opioid. It's the only opioid that you can buy over the counter. And in fact, during Hurricane Harvey in Houston a couple years ago, this was in hot demand. People were stealing big bottles of loperamide from Costco and Sam's Club. Because if you grind up a certain amount of loperamide and snort it, you won't go through withdrawal. So unfortunately, during Hurricane Harvey, people couldn't get a hold of their heroin. Their heroin dealers all left town because of the flooding. And so loperamide, it won't get you high, but it'll keep you going through withdrawal. And then, of course, there's methadone, which is a full opioid, and again, it is also used as a treatment for opioid use disorder. So these are all really common. So here's the illicit opioids. So these opioids don't have any medical use. So you can see acetylfentanyl. So there's another chemical group that's actually been added to the fentanyl molecule, and that makes it a completely different molecule, and it has no medical use. And it changes the activity so that it might be more powerful, it might be less powerful. It's hard to say as compared to regular fentanyl. And then here we have carfentanil, which used to be used as a veterinary product, and it's about 10,000 times as potent as morphine. So very, very ultra potent. These are what we would call, if you ever hear anybody say ultra potent opioids, this is what they're talking about. Illicit fentanyl, non-medical fentanyl. The DEA calls them IMFs, illicitly manufactured fentanyl. That's what we're referring to.
Dr. Alonzo, we do have a question, so I'm not sure if you want me to hop in.
Yeah, no, absolutely. Yeah, let's do.
Okay, so I'm not sure if it's on this this slide or the previous slide, but Gabriel asked, but it doesn't pass the blood-brain barrier, right? So
what doesn't pass the blood-brain barrier? Loperamide?
I think it came in when you were on the previous slide. Yes, he says yes.
Well, it does pass the blood-brain barrier, but it actually doesn't interact with the mu receptors that causes euphoria. So it doesn't interact with it doesn't cause euphoria the way the other opioids do. So they all have like a slightly different receptor profile, but all opioids cause constipation. All of them do. So we're just capitalizing on the fact that loperamide doesn't actually cause euphoria, but it does cause constipation, which all opioids do. Does that make sense? But it still will occupy the receptor, so it'll keep you from going through withdrawal. So,
okay, if we have another question, I'll just hop on if that's
sure.
Okay.
Yeah.
And okay. He says, it was very helpful, thanks.
Okay, great. So these are not opioids. So there's a lot of confusion in even the medical community. Like I actually had a medical student argue with me that cocaine was an opioid. It is absolutely not. It's sort of like, I would say from a pharmacological perspective, it's sort of the opposite of opioids. So benzodiazepines, although they are controlled substances and they are abused in the community, they are not opioids. And the reason that that's important is that if you have a naloxone rescue kit and you absolutely know, that somebody was exposed to one of these drugs, a benzodiazepine, naloxone will not work. So if they're experiencing an overdose or respiratory depression from something else other than an opioid, then unfortunately naloxone will have no effect. So these are all drugs that, probably pound for pound, Xanax is one of the most problematic drugs that we see circulating in the community that causes a lot of substance use disorder. So here's, cocaine and methamphetamine, and that includes crystal meth and all the permutations of that. Those are amphetamine analogs. So they have a lot more resemblance to, say, the medications we use for ADHD and caffeine and drugs we use as antihistamines. Those are all amphetamine analogs. And of course, like methamphetamine is a huge problem in the community, but again, naloxone is really of no use there for in an overdose situation. Here's some sleeping agents. Again, these are not opioids. Kratom, have you ever heard of Kratom? Do people know what Kratom is? You guys heard of Kratom? Have clients that maybe use Kratom? So I see a couple of responses that maybe that you've seen it. It has this weirdo quasi-legal status. The DEA tried to regulate it as Schedule 1, which means no medical use and completely illegal, but then they backed off of that position. It is a partial opioid receptor agonist. So again, like in the brain, those receptors that opioids actually interact with and exert their effect, kratom, when it's used as a tea, lots of people use it as a tea. They make an infusion of it and they drink it as a tea, and it will mimic the opioid type effects. So we don't know much about it. It's one of those things that nobody's, we haven't gravitated towards studying it, but it's a, you can, I've seen it in driving around Texas. I've seen it for sale at various locations. And here's ketamine. Again, ketamine is psychoactive, but it is not an opioid. And then we have the synthetic cannabinoids, like in Houston, we call that Kush. Spice, K2, it's known by a lot of colloquial names. Again, it is highly psychoactive, but it is not an opioid, and therefore naloxone has no effect. Is there a question, Amy? I see another question or comments. I saw some stuff pop up in the chat, so I want to make sure that everybody gets their questions answered.
Yes, let's see. How well understood / studied is, I'm not going to be able to say this, 7-hydroxy, let's see, Wimford, is there a way for me to push this to Dr. Alonzo, because I can't pronounce it?
Let me see if I can see the chat.
It came in under Q&A, so if you can, do you have a Q&A icon? You can click on that, and there are 2 questions in there.
Okay.
Or 2 comments.
Not at all. So no, there's hardly any studies about kratom or kratom analogs, or there's just, so you got to understand, like research, we have to have, there has to be some medical use. We don't get, as a researcher, you have to have, there has to be some sponsor of the research, and so for a lot of this there isn't any. So if we can't get it if we can't get sponsored by the federal government to study it, and right now they're just not wanting to study any of those things. We do study a lot of the synthetic cannabinoids. Partly that's all written in blood. So if there's a big an outbreak of overdoses associated with an illicit substance, then all of a sudden money becomes available for the research community to take a look at it. So unfortunately, synthetic cannabinoids have caused a lot of mortality, and so that gives us an opportunity to take a look at those substances, but that's not a good thing. I mean, you have to wait till people die before you're able to actually get funded to look at stuff. And right, so yeah, kratom's not well studied at all, unfortunately, but I hope to someday. So, okay, so why do we still use opioids if they're such a pain in the neck, right? And the opioid crisis is actually heating up right now because of the pandemic, and we'll talk about that in a second. Well, for surgical and oncology use, there just isn't anything else. Nothing. They are extremely good at pain management. The unfortunate piece is that they're psychoactive. And so if you could get something that isolates pain management but isn't psychoactive, oh boy, you really have something then. But we just don't have any opioid. A huge surgery, you are going to want opioids. Anybody comes in and says, like, I want to provide you with acupuncture, you're going to throw them out of your room. So, and they're also used for pain, cough, and diarrhea, as we discussed. The big issue is the euphoria, stress relief, which leads to self-medication. Unfortunately, that the euphoria, which is like that feeling of wearing rose-colored glasses, right? Everything's okay. I had one of my patients described it as when she was starting to develop a high dependence on an opioid, was like wearing a sweater for your insides. That's how you feel when you take it. So everybody that develops tolerance and dependence doesn't progress to substance use disorder. I mean, there's certain individuals that we want dependent and we medically manage them that way, especially in hospice care and oncology, where you might be end of life or very severe illness. We will have people that develop tolerance and dependence, but they don't necessarily go on to develop substance use disorder. But the fact that all opioids, it's just a matter of time, will cause tolerance and dependence, put you at risk for substance use disorder. So that's one of the big issues. So I see a chat came up. Just please I'll put everything in the chat and then I'll be able to get to it. That'll be cool. Yeah. Okay. So here's like by the numbers, and public health data lags a little bit. So this is 2018 data, and then I'm going to show you what the AMA projected data is for 2020. So we have a little bit of data on 2019, what happened, and 2020. So 130 people die every day of an opioid-specific overdose. I actually don't know how many die from opioid overdose all causes, but opioid-specific overdoses, that's 130 per day. So that's the equivalent of a regional airliner crashing, you know, at Bush International Airport every day. That's, you know, and if that happened, if we had a regional aircraft crash at Bush International every single day, we would have a huge public health response to that. But unfortunately, because it's a substance use disorder and that still carries a lot of stigma, and in the community, we really don't have that huge public outcry of like, okay, how can we get these folks care? In 2018, 10.3 million people were actually willing to tell me on a survey that they had misused prescription opioids. 47,000 people died from overdosing on an opioid in 2018, and actually that was a decrease from 2017. 2017, we estimated was about 52,000. So that was a slight decrease, but unfortunately, because of the pandemic, all those gains that we made have all been lost. 2 million people were diagnosed with opioid use disorder, and as you guys know, that's diagnosed with. That's the tip of the iceberg. Most folks with opioid use disorder are never diagnosed. Almost 1 million people were willing to tell us on a survey that they had used heroin in 2018, and 81,000 had used heroin for the first time. 2 million people misused prescription opioids in 2018 for the first time. So the point is that these numbers are huge compared to even other medical disease states. It's you know, actually quite shocking that we don't have substance use treatment facilities popping up all over the place, and that are not commercial. You know, that would be, you know, public access type facilities, because we do have facilities, but unfortunately they are actually facilities that require insurance, and so that's very, very problematic. And a lot of folks, especially in Texas, I'm not sure about Louisiana, but in Texas we have 30% of the citizens of Texas, this was before the pandemic, are uninsured. And you can see, oops, I skipped that, but here it's $696 billion, you know, billion, 2.5 trillion over the next 4 years is what it's going to cost us relative to lost wages, cost to the community, and you know, cost of care for individuals, incarceration of individuals. That's the cost to us. 2.5 trillion over the next 4 years, which is really, really impactful. So this kind of shows you what happened all the way up to 2018. So it looked like in 2018 we were doing better, and this breaks down females to males, you can see from 1999 this really huge increase in the number of overdoses by an opioid that you know had really taken off. Here's 2014, and that was a watershed year. Does anybody know what happened in 2014 that changed everything, that caused this huge increase? So it's something that the DEA did, and it was meant to be helpful, but it actually pushed people towards heroin, and then that pushed people towards fentanyl. So in 2014, what happened, the DEA rescheduled hydrocodone. So that's Vicodin and Norco. They rescheduled it to Schedule 2. That might seem like a nuance, like, so what? Well, to a prescriber, it's a big deal. The difference between Schedule 3 and Schedule 2 relative to how much scrutiny the DEA puts on your prescribing habits, it's tremendous from one to the other. Schedule 2s have, you know, it used to be that you had to write that on a special, in 2014 certainly, you had to write that on a special prescription pad, you had to put your DEA number on there, there's no refills allowed. It's very observable. The amount of C2s that you're writing is hugely observable. So prescribers don't like to do it, so they stopped doing it. So all of a sudden you had developed and prior to this, you could get Vicodin all day long, and it was not an issue. And so all of a sudden, you can't get Vicodin anymore. So, and in one day, the street value of Vicodin went from almost nothing to $20 a tablet. You know, when that restriction occurred. So that pushed people over to heroin, which here Blackheart heroin's about $5 a bag. So it's just like an economic issue. So are there some questions? Let me see. Let's chat. Many who do not work in SUD field don't understand the difference between physical dependence and addiction. Please explain the difference. Oh, okay. So dependence is when the same dose doesn't give you the same effect. So if I was managing someone for pain, I would have to, I might have difficulty managing their pain on a particular dose. So let's just say I was managing them on MS Contin or Norco, you know, so they were getting 5 milligrams of the hydrocodone component, and they keep telling me they have breakthrough pain. Well, I would have to increase the dose because the same dose that used to work doesn't work anymore. But that doesn't mean they have substance use disorder or addiction. Substance use disorder is now, in the DSM-5, what we use for diagnosis, that means that they're starting to exhibit behavioral components or behavioral symptoms that are what you guys would call, I guess, drug-seeking behavior outside their medical management. So dependence is just a physiological dependence on the drug, which all opioids cause. But substance use disorder is when, you know, is a problematic pattern of use of the drug that has nothing to do with a medical diagnosis. Okay, does that help? So if you start gravitating towards you know, drug-seeking behavior, like and that starts to take over the rest of your life. And in psychiatric services, we always talk about it this way. If it starts to affect your capability to go to work or school, if it starts to affect your self-care, you know, your care of daily living, those kinds of activities, and when it starts to impact your relationships, that's when your substance use disorder is probably clinically diagnosable. So if you think about it, the substance use disorder piece is the behavioral component, the things that a person starts to do to actually maintain, you know, to start maintaining the substance use outside of medical management. So if a person's just taking their medication as prescribed, that isn't, you know, necessarily substance use disorder. Okay? That's a short answer, but hopefully that helps. Tramadol did not get moved to Schedule 2. Tramadol is Schedule 4. I hope that answers some of the questions. So here's the projected numbers. So I had to doctor this chart a little bit up for 2030. So in the year 2030, which may sound like it's really far away, but here's us, 2020, it's really not that far anymore. The projected number of overdoses are now in the 250,000 range per year, if nothing changes. If we stay on the same trajectory, like here we were in 2017, and then we made a little bit of headway in 2018, then 2019 was horrible, and we jumped all the way back up again. And then 2020, according to the AMA, it's gonna be actually double what 2017 was. So that's about double. And then if we stay on that same trajectory, just using math and the slope of the line, that means in 2030, 250,000 people just from opioid overdoses alone. And it's really unfortunate. Part of the reason for that is opioid use disorder is really tough to treat unless you have medication-assisted treatment, which is really, really important. So what does that look like? You know, so here's 2020 data. This just came out, and I put like the link to this for you. This just came out September 8th, 2020, where the American Medical Association, they have access to a lot of hospital data, and what they're projecting is double the amount of opioid overdoses in 2020, primarily due to the pandemic. Any guesses on why the pandemic has been such a driver for overdoses? You can put them in the chat. I'll look if you want to put your answer in the chat. But it has been really problematic. So isolation, certainly isolation away from your recovery assets, but there's a really, anybody ever worked for a methadone clinic? A federal methadone clinic? So unfortunately, when the pandemic started, the methadone clinics did not have put policies and procedures in place to keep people, and if you know anything about methadone treatment, so this is one of the primary ways we use drugs that we use to keep people in recovery is methadone, and you have to go and get your dose every day from a federally qualified methadone clinic, and they provide a lot of support for you. And unfortunately, the methadone clinics all closed during the pandemic, and they would actually issue somebody 2-3 weeks worth of methadone, and you got to consider you're only used to getting your day's worth. So they overdosed on the methadone, unfortunately. So that we had a bunch of overdoses due to methadone. Buprenorphine or Suboxone is another treatment that we use for people with opioid use disorder, and it became very difficult to get. So pharmacy closures, so people just didn't have the access to care that they normally have, and people with opioid use disorder need a lot of care. They need a lot of support to maintain their recovery. So it's a disease state that is associated with chronic relapses. So so you constantly have to recommit, and so not being able to access your recovery and your group, you couldn't go to group, like you guys say, isolation, depression, anxiety. You couldn't go to group anymore, not face to face, and not everybody has a laptop to join a Zoom session. So it was really, really difficult. But this is a really great state-by-state report on the problematic increases in opioid overdoses that actually are attributed to the pandemic. So what does 250,000 deaths kind of look like? So, look at breast cancer. So we have about 42,000 deaths in the United States from breast cancer yearly, and that is tragic. But that number, due to really great personalized treatment, is dropping, and that disease state has, a lot of support. You look at deaths from stroke, deaths from diabetes. So these are all extremely impactful chronic disease state, but not one of them causes 250,000 deaths per year. Due to the opioid crisis and suicide, the U.S. life expectancy has dropped. For the last 3 years in a row, we have a dropping life expectancy as opposed to, despite all the medical advances that we have a dropping life expectancy. For a public health person, that's the kind of stuff that makes you fall out of your chair. You're like, what the, that's bad. And here's 1918. I used to give this presentation before the pandemic, and nobody knew what the significance of 1918 was. Now everybody knows the significance of 1918, right? That's the last big icky pandemic, the Spanish flu. So this is the big joke of opioid crisis: is who does it impact? Everybody. And you might think, like, why do I have a baby on there? How could a baby have substance use disorder? Well, babies don't have substance use disorder, but what they do have is neonatal abstinence syndrome. Have you ever, NAS, N-A-S, have you ever heard of that? It's wicked bad. It is a syndrome that you're born with tolerance and dependence because your mother was a user of opioids. And so you're born with an immediate tolerance and dependence. You go through withdrawal when you're being born. And these guys don't do that well. There's really no great clinical protocols to address them. I mean, we do the best we can, but sadly, the epicenter for neonatal abstinence syndrome is San Antonio, Texas. 30% of all NAS cases actually occur in San Antonio, in the world. So if you want to go study NAS, neonatal abstinence syndrome, you go to San Antonio. It's called Bexar County. And unfortunately, at Texas A&M, we actually just got a huge grant to study that. But then again, remember what I said, that's all written in blood. When we get a grant, it's because it's so bad that finally it got somebody's attention, and so we're actually going and studying that. So here's just kind of an overview for you. The inherent qualities of opioids that can easily contribute to misuse. Not for everyone, but a certain percentage of people, these become very profound. So the euphoria, stress relief, that's not good. They're not prescribed for stress relief, they're prescribed for pain. But people notice that they help with stress, and ergo, that's part of the risk factor to develop substance use disorder. All opioids cause tolerance and dependence. It's just a matter of time. Now, does everyone with tolerance and dependence progress on to substance use disorder? No, but you're certainly at risk for it. Illicit opioids are very cheap and easy to get, and that is super problematic. Are there any other questions? Did anything pop up in the chat? Okay. So here's like the relative potency. So when you see on the news or you hear about illegally manufactured fentanyl, now why as a dealer, now I'm your drug dealer, so why do I like fentanyl? What characteristics of fentanyl do you think I like about it as a dealer? Now, bear in mind, this is made in a dump truck. It's not about quality control. And okay, I have an answer in the chat. So it is highly addictive, and that's a good thing. You're going to come back for it, but yeah, so you only need a little. It's easy to transport. That's right. That's it. Ling, ling, ling. I have a winner. I can put a ton of this stuff in my tires as I cross the border. And really, whatever comes across like a monitored border is a fraction of what comes across where the border's open. And in Texas, we're particularly challenged with that. We have this gigantic border, and we can't monitor it all. So the cartels will actually send over a truck underneath some strawberries with a couple tons of fentanyl in it, and the Border Patrol will find it, and they'll do the jig. But meanwhile, 500 times that is actually going across the border someplace else. So that's actually just considered the cost of doing business. So yeah, so here you can see the relative potencies. So as a dealer, why do I not like carfentanil? How come I don't cut my stuff with carfentanil anymore? And they don't anymore. Can you think of a reason why? So it's 10,000 times the potency of morphine. What do you think that means? Okay, I got a taker. I got some takers. Too dangerous, yeah. So I don't care about you dying. I really don't care about that. But what I care about as a dealer is being able to sell my stuff, right? So if I kill my customers off, so the response is too variable. So nobody knows. It's never been tested in humans. Nobody knows what's a safe dose. And I get asked that all the time, like, what's the safe dose? Who knows, right? None of these drugs are studied in humans. The illegally manufactured stuff, we don't. No one knows. So you're quite right. It's the human response is too variable and it kills people off too fast, and then you don't have anybody to sell your stuff to. So how do we prevent opioid overdose deaths? So here it is. These are some of the strategies that at Texas A&M we've been incorporating and are sanctioned by the United States Health and Human Services Commission. Do you know what an X waiver is? Have you ever heard of that? An X waiver? What a doctor with an X waiver or a nurse practitioner with an X waiver, what that might mean? Anybody know what that means? Okay, so that means you have to have a separate, in order to be able to prescribe Suboxone for somebody to treat their opioid use disorder, you actually have to have a separate DEA number. And we call them X waivers because this DEA number will have an X at the end of it. And right now in the United States, less than 3% of those that are eligible to get X waivers and actually could provide this treatment actually have X waivers. And of those that have X waivers, less than 8% actually use them. So we have a tremendous mismatch in the number of people who can prescribe opioids versus the number of people who can prescribe Suboxone to treat opioid use disorder. There's a huge mismatch. So, and increasing distribution and training for Naloxone kits. So that's where you come in. So, taking the time to listen about Naloxone is a great step. Drug take-back locations and events, those are usually organized by the DEA, and traditionally they're in October and April. Harm reduction, that can mean needle exchange programs, HIV programs that also are co-located with maybe some literature for substance use disorder treatment. All those things are considered harm reduction. Improving coordination of public health and safety sectors, improving opioid prescribing and better practices for pain management. That's something that we've been focusing on at the Health Science Center. And the I looked at Louisiana's numbers, and actually the number of opioid prescriptions has gone down dramatically since Louisiana provided the prescription drug monitoring program. And that's what we're talking about next. And that means that a practitioner or a clinician that writes a prescription for a controlled substance has to enter the prescription monitoring program and look at the person's controlled substance fill history prior to writing that prescription for a controlled substance. And then also the pharmacy that fills it, they have to do the same. So before you get a controlled substance, somebody is actually looking at a nationwide database to see how many controlled substances you filled in the last 90 days, in the last 6 months, to determine if you have what would look like a pattern of behavior of misuse. Harm reduction, here's some of the features of harm reduction. So medication-assisted treatment, and what I mean by that is using a drug like Suboxone or like methadone to treat somebody to maintain their recovery. So technically they're not in abstinence. They're abstinent from heroin, but they are not abstinent from treatment. So, and it actually works. The reason we do it is because it's evidence-based. It increases the length of their recovery, and it increases the time in between relapses with the illicit substances. And the two drugs that we use the most, which would be methadone and Suboxone, those are, they are not euphoric. They're not associated with the euphoria that's associated with heroin. So naloxone rescue kits, it's not treatment, it's live to fight another day. Syringe exchange programs, keeping people from using dirty needles if they're going to use. What you don't want is for them to get Hep C and HIV or some other dread awful infection, which makes them, orders of magnitude more difficult to treat. PrEP, which is pre-exposure for HIV, fentanyl test strips, which in Texas actually have a quasi-legal status, but maybe have better legal status in Louisiana. Hepatitis C testing and HIV testing, any positive change that makes the person, their pattern of use either decreases their pattern of use or decreases the risk associated with their pattern of use, and establishing that trust relationship with folks so that maybe you get to talk to them about entering treatment one more time. So rescue kits, this is just from the Surgeon General. Surgeon General doesn't come out with generalized programs, but basically his message to the American public was know how to use a naloxone kit and keep it within reach, kind of like a fire extinguisher. So here's how it works. So we were talking earlier about the blood-brain barrier, right, and receptors in the brain. So this is Dr. Alonzo's golf tee analogy for receptors, opioid receptors. So these blue golf tees are opioid receptors in the brain, and the red golf ball is an opioid. And the opioid will come into the brain through the blood and will attach to these receptors that it likes. It has an affinity for, kind of like magnets, it likes it. So at some point, when 60 to 70% of these receptors are actually full with an opioid, you stop breathing. So the reason you die from an opioid overdose is respiratory depression, or you slowly stop breathing. So at 60%, 70% occupancy, that's when a person experiences slow to no breathing or respiratory depression. So naloxone is this green lumpy ball, and it actually has a higher affinity for the receptors. It likes them even more than the opioid likes them, and it actually can boot the opioid off of the receptor. The naloxone occupies the receptor, but it has no activity of its own. So immediately the person will start breathing again. So that's the way drugs work, is they all have a particular way they interact with the receptors. And naloxone, although it occupies the receptor, it doesn't do pain management, it doesn't cause euphoria, it doesn't do anything, it just occupies it. And so the person will immediately start breathing again. That's what you're trying to do, is restore breathing. Are there any questions about that, about how naloxone works? So now you can kind of see why it doesn't work for any other drug, because it only works for opioids because it specifically targets these opioid receptors in your brain. So unless that drug is occupying that opioid receptor, it doesn't matter. Any questions about that? Okay, so here's some facts about naloxone. So the kind of naloxone that we distribute to the community is nasal naloxone. And I actually have one right here that I can show you. I usually have them all over the place so that I can show you one. But if you read through those, you can see what how it works. Sugar plums. I thought I had it right next to my desk, but I must have. It's a tiny nasal. Oh, here it is. Ha! Okay, so here's what it looks like. Can you all see that? This is nasal naloxone. Very simple packaging. So it's absorbed through the nasal mucosa, just like fluticasone nasal spray. It reverses respiratory depression or slow or absent breathing, restores breathing. The patient will eventually experience withdrawal due to administration of naloxone, but not right away. That takes some time. You know, they're dead out. They're absolutely unresponsive. So the first thing you want to do is have them restore breathing, and then after that, hopefully the EMTs will show up. So it works in 1 to 3 minutes. It lasts 30 to 90 minutes. and can neither be abused nor cause overdose. And it's available like this as a nasal spray, or it's available as an injection. So think of it as a fire extinguisher. When you need it, you need it. Nothing else works like it. If you don't have it, you wish you did. This is Texas law, and I think that Louisiana law is very, very similar. So there's a standing order that says that it is a prescription medication, but at the Louisiana state level, there's a prescription written for all citizens of the state of Louisiana to be able to have it without having a prescription that's actually written for you. So that means it is a prescription medication, but you can have it without a prescription. Also, you can get it prescribed to you for somebody else. Let's say that someone in your family maybe had a risk of substance use disorder and you wanted to have a kit on hand. A doctor can write a prescription to you that's really not meant for you. And if you're everywhere in Louisiana, I did look this up, it's covered under the Good Samaritan law, just like if you render assistance at an accident, like you do CPR, and if you administer naloxone in good faith and regardless of the outcome, you can't be prosecuted. So, and in Texas, there is no, unfortunately, there is no, we don't have medical amnesty, but you guys do. So, and that means that if a person is using, they can actually call 911 and not have fear of prosecution because they've been using too. So that actually is meant to encourage people to call 911. So here's the different type of kits that are available in the community. There's an injectable, and this is, we've been using this since 1961. You know, every day and twice on Sunday in the ER. If you come into the ER and we don't know why you're unconscious, we give you naloxone just, you know, as a Hail Mary. So I see a question or comment in the chat. How do you access that new? So all you got to do is go to a pharmacy and ask for a naloxone rescue kit. Now it's not free; you have to buy it. And also through community distribution programs like mine, you can get it for free. So I'm going to be sending kits to the Women's Foundation so that you could come and pick yours up if you wanted to. So there's also a question says, I have also heard you can use Narcan even if you don't know what they overdosed on. There are no adverse effects. That is true. Now, don't get your hopes up though. If it's something else, you know, you can use it. It won't have any ill effects. But if they're overdosed, if they're unconscious because of an alcohol overdose, or if they're unconscious because of some other exposure, unfortunately, it won't work. But we do it all the time. I do it all the time. And you're right, I would do it if I even thought like anything that there was any possibility that it might work. Capital Area Human Services District has kits that are being distributed. So that's an excellent resource. If anybody knows of resources where naloxone rescue kits are distributed, that would be great to put in the chat for others. But I am actually going to send some of ours to the Women's Foundation so you can pick them up from them too. So this is $6 a vial. This is cheap and still works really good. I used to give out kits that had the vials in them, but they're kind of intimidating, drawing it up and trying to inject somebody. It's a pain, right? Here's a pre-filled needle, and you just put this purple cartridge inside the yellow syringe. This, you can see the price goes up to $80 per syringe. We used to do that too, because once upon a time, these were $4 per syringe. And here it is with a nasal atomizer, this white cone, you screw it onto, instead of using the needle, you screw it onto the top and take the needle off, and then you can make a mist out of it, kind of like what this does. Yeah, it wasn't FDA approved up until like maybe about a year ago, and it's a lot of fluid. So, and again, you know, it's $80 per syringe, so you pretty much need 2 of them, so that's $160. This is an auto injector, and I used to have these too to give away, but look at this wholesale price, $3,000 for a box containing 2. It's really cool though. It talks to you and says, if you're ready for injection, remove the red cap, place on the person's thigh, count to 15 so that you make sure that you get the whole dose in, but it's still the same drug, exactly the same. And you can see that that price is prohibitive, and none of the insurance companies actually cover those anymore. And here it is. Here's the kits that most of us give out, is the nasal Narcan spray. So there's 2 doses. In most kits, there's 2 doses. If somebody's been exposed to one of the ultra-potent opioids like the illegal fentanyl, most of the time they need 2 doses to bring them, get them out of respiratory depression. So again, it's absorbed through the nasal mucosa, so that means the person does not have to be breathing. Well, they're not breathing. That's the whole point, right? So it actually gets absorbed right through your mucous membranes in your nose, right? It goes right to the brain. So the person does not need to be breathing. You're not relying on them absorbing it through their lung tissue. It never goes to their lung tissue. It gets absorbed right here. And here's the average wholesale price is about $140 for 2 of these devices. But again, it's that same old drug from 1961 that costs $6 a vial. Who's at risk for an overdose? Anybody who has had a history of opioid poisoning or a previous overdose. Remember, it's a chronic relapsing disease state, which is characterized by relapses as opposed to, other disease states that might have a resolution. History of illicit or non-medical opioid use. Certainly, if you're under treatment for opioid use disorder, you would always want to have somebody in your family have a kit just in case. If you are under medical management and you have more than 50 milligrams of morphine a day, and we're trying to teach physicians to co-prescribe Narcan so that if they have a patient that is at this level of opioid use, that they have it available, and to teach the family how to use it, because once you're overdosed, you can't use it on yourself. You're unconscious. Use of opioids from multiple prescribers or multiple pharmacies. And nowadays that's becoming less and less due to the prescription monitoring programs, so that the pharmacies and the prescribers have like a visual on that happening, so it doesn't happen as much as it used to. Use of interacting drugs like alcohol or some of the benzodiazepines we talked about, like Xanax, and antidepressants can up your risk of a possible overdose. But you're never more at risk of an overdose than when you just got out of a drug treatment, enforced drug treatment or detox, like you get at a correctional facility. How come? Why? Why does enforced abstinence, why do they all go and overdose as soon as they get out? Okay, I'm going to look at the chat. Your tolerance is gone. So for people that don't understand tolerance, that means, again, think back like, okay, we said physiological dependence, you need it. Tolerance is that idea that the same dose that you used when you were a user, you had that same dose. Okay, so let's say you did a half of a syringe of heroin from your dealer, and that got you high. Well, now you haven't been using for at least 30 days, maybe up to a year, and that same dose that just used to get you high, you will now overdose and die from that. Abstinence, enforced abstinence is not treatment. The reason that you use in the first place, all those reasons have not been addressed. So that all the reasons that you use, and I had a professor that, substance use disorder is highly associated with adverse childhood events. And that doesn't mean just sexual abuse, that's any kind of abuse. Food shortages, if you're at risk for homelessness, all those kinds of things contribute to substance use disorder risk. Let's see. There's a question: how do you obtain that one unique prescription? So it's not a prescription; it's a policy that's written at the state level. So if you wanted to go to a pharmacy and request a Naloxone rescue kit, you can do that, and you don't have to have a prescription written for you. So the Walmart, Walgreens, CVS, Kroger, HEB, all those corporations have committed to honoring the standing order and to providing naloxone rescue kits. However, you do have to pay for it. It is not free. The advantage of going to a community distribution program is you can get it, like I give them out for free. So I have mine are covered by state funding. So does that make sense? So you can go to a pharmacy, and if they honor the standing order for Louisiana, they will provide you with a naloxone rescue kit, but you have to pay for it. So if you paid cash, they would have a cash price, or if you wanted it on your insurance, then you would pay your copay. Okay. Okay. What does an opioid overdose look like? So forget about everything you know from Hollywood. It doesn't look like that. It's never instantaneous. It never happens like where you shoot up and you die. You start frothing at the mouth and all that jazz. It's more like happens 1 to 3 hours after the last exposure or use. People just get tired. They go someplace to be alone, to sleep it off, and they overdose and die. The opioid, remember we said the opioids attach to too many receptors in the brain that control breathing, and at some point, you just don't breathe anymore. Your brain doesn't tell you, hey buddy, you need oxygen. That part of your brain turns off. So no oxygen to the brain, decreasing consciousness, which leads to coma, which leads to death. This is acute intoxication, so you're not overdosed yet. The pupils might be very constricted, although people with dark eyes, that might be really, really tough to see. The person will be mildly responsive. We call them touch and goes. They'll nod out, but they'll be like, huh? They'll be able to wake up. They'll be itchy. They'll scratch, and mildly responsive. But you have time to get the person to an emergency department under these circumstances. So this never happens. I wish it did, sort of, because then I could tell what they were exposed to. But unfortunately, whatever happens, they use and they get rid of all their stuff, and then they walk around for a while, and then they feel tired, and they go to the ladies' room, and they sit in a stall, and they overdose and die. So here's what it looks like, though. Breathing will be slow or absent. For me, in emergency response, anybody who's not breathing, I don't have to know if their pupils are restricted. That doesn't, if they're not breathing, that's good enough. They need help. They won't be moving. They will not be responsive. So if you do a sternal rub, which is the gold standard for stimuli, they're not going to respond. They might look blue. Their lips might be blue or pale. They might be cold and clammy. All those things are possible. You can hear gurgling sounds, maybe. If they're breathing a little bit, it sounds like sleep apnea. It'll go like, and then they won't breathe for like a whole entire minute, but they cannot be woken up. They will not respond. So that is a major feature, is that you slap them, drag them, none of that'll matter. They cannot be woken up. So death from an opioid overdose is the result of hypoxia. Think about like putting a pillow over somebody's face. That's exactly the same. Or drowning. Those are other ways you can die from hypoxia. So what should I do if I think someone has overdosed? Here's the Opioid Overdose Prevention Action Plan. So try to rouse the person. Number one, try to rouse the person. You can do the sternal, hey, are you okay? Person doesn't respond. We want you to call 911 immediately. And that way somebody will bring more naloxone. It is possible that if they've been exposed to an ultra-potent opioid, that 2 doses won't be enough. So administer the first dose of naloxone. So you just actually put it up, see it has this plunger right here. It doesn't have a cap on it or anything like that. You don't have to shake it. There's no preparation. You just put it up their nose and press the plunger, and that's it. It's about 0.1 milliliters of fluid, so it creates a little mist. That's it. That's all you got to do. Start rescue breathing, which is 1 breath every 5 seconds. So it looks like 2, 3, 4, 5. 2, 3, 4, 5. Now in the kits that we provide, we actually provide a CPR shield to protect you. you know, and we did this before the pandemic because we don't want people feeling uncomfortable about HIV transmission or any other infectious disease transmission. But yeah, do use the CPR shield when doing rescue breathing, especially now. If no response after 2 to 3 minutes, you can give another dose of naloxone. So remember, they come two to a kit. So you would have another dose available, and you don't have to switch nostrils. You can put it in the same nostril, the other nostril, whatever you want to do. It doesn't matter. You would continue rescue breathing until the person responds, and the way they're going to respond is they're going to start breathing again. They're going to start breathing. So until the EMS arrives, and if breathing is restored, you want to place the person in the recovery position, and that looks like this. So this keeps them from, if they should vomit, they won't aspirate their own vomit. So you just roll them onto their side, and then they're supported by their elbow and that arm. Okay, so these are overdose response myths. None of this stuff works. In the recovery community, there's lots of, you know, mythology about if you don't have naloxone, try one of these things. None of this works. If you put some ice on somebody's body who's unconscious from an opioid overdose, they'll be cold and dead. If you give them a cold shower, they'll be wet and dead. If you burn them or punch them, you're going to have to answer a lot of questions because they will have a bruised and beat up body, but they will still be dead. So you don't have to worry about hurting somebody with naloxone. Like one of the other participants said earlier, you know, give it no matter what. You know, it might not work, but it might. You know, if you don't know what they've been exposed to, you can give it a solid try. But unfortunately, the only thing that it does work to reverse is an opioid. But maybe that'll be enough. So you can definitely feel comfortable doing this because this is the only thing that works. When you bring a person to the ER, we start a drip of this, an IV drip of naloxone, because we don't have anything better than you do. You know, this is all there is. So this is, this is the way to go. Oh, gosh, you know, Prince, when Prince died, this is so unfortunate, and this is why this training is so important. Prince died in his own home, in his own elevator. His bodyguard was by his side. His bodyguard actually had nasal naloxone on his person, but did not use it on Prince because he said that he didn't know how. He was uncomfortable using it. So that is super unfortunate, right? You know, you wouldn't ever want to be in that situation. Okay, so does anybody have any questions or comments? I have some cases that we could talk through. What comments do you have or questions? Oop, we need to do that. Any issues, questions about the standing order? I know that was like sort of an issue. Any questions about naloxone or having it on you? So one of the big questions I get all the time is, can you leave it in your car? So the answer is yes, but in a Louisiana summer, it'll slowly lose effectivity. If it's exposed to heat over a really long period of time, it won't turn into poison or anything, but it'll slowly lose effectivity. Now at the Texas A&M Pharmacy School, we baked it. We've done all kinds of stuff to it to see how stable it was, and it is extremely stable. But you know, the ideal conditions are just, you know, room temperature, not exposed to extremes of heat and light. It'll work longer. You know, it'll maintain 100% effectivity longer. Here's a question in the chat. I have heard that it is important that EMS takes them to the hospital since they could overdose again. That is true. So remember we talked about it works for like 90 minutes. So after that, it gets metabolized by your body and it'll set those receptors free. And depending on how much opioid is still circulating in the victim's body and what kind of opioid it is, they could re-overdose. That is possible. So you definitely want, this is an automatic trip to the ED. Yeah, definitely want to make sure they go to the ED. So, and then the second part is also good to let people know that they should lock up their opioid meds. I would say not have opioid meds. Why do you have them? You know, so if you got it treated for a dental procedure 2 years ago and you're keeping your Vicodin around because you think, you know, don't do that. Just get rid of it. stick it in the kitty litter, stick it in coffee grounds. Now, if you have somebody at home who's being treated for cancer, or who has to be on opioids for some other reason long term, then yeah, certainly lock them up. But if you have leftover opioids from some dental procedure or some broken bone or something that happened to you a couple of years ago, don't keep them. Get rid of them. And that's what drug take-back days are all about, is giving you an opportunity to clean all that stuff out and get rid of it, and not have that hanging around. But that's a really good comment. So here I have a case for you. You enter the apartment on campus. So sorry, I end up dealing with a lot of stuff with the university. So lots of my cases are campus related. After an anonymous 911 call, and find a 20-year-old male passed out on the floor. So in the chat, tell me what signs and symptoms would indicate a potential opioid overdose. What do you look for? So he's passed out, but yeah, so one person said passed out on the floor. Yeah, clammy, unresponsive, slowed or absent breathing. They might not be breathing at all. Unresponsive, all those are really good. That's enough for me. Unresponsive and slow or absent breathing, I don't have to look any further than that. Sometimes when I'm teaching the docs, the baby docs, they'll say like, well, I would assess for restricted pupils. I'm like, it's dark. How are you going to do that? You're kidding me, right? So I probably wouldn't care about drug paraphernalia. I don't know that I would look for that, but I would definitely look at stimulating them with a sternal rub, yeah, and seeing if they woke up or were responsive. But those are all really good answers. He does not respond to a sternal rub. What should you do before administering naloxone? What's the next step? So you want to get somebody else on their way. Who would, yeah, call 911, because they're going to have a lot more naloxone than you will. So call 911 before you start fumbling around with your naloxone rescue kit. So you want them on the way as soon as possible. And if you guys live in a city, you might not think about this. You might think like, well, 911 response has got to be pretty fast, right? But I live out, in College Station, in this town called Snook. It takes a solid half hour, 30 minutes for 911 to show up. 30 minutes. 30 minutes without oxygen to the brain, that's not good. So I want to get them on their way as soon as possible. So, that's part of the reason we said call 911 first, to get emergency services on their way. You administer naloxone. What should you do next? What's your next step after administering? So start rescue breathing. Right, exactly. Start rescue breathing. What will happen when you administer naloxone and this was not an opioid overdose? What happens if you give the person naloxone and they're not in an opioid overdose? It's something else. Nothing. Perfect. Okay, that's right. Okay, so here's another case. You come across a couple in the park that appears to be intoxicated. The young woman loses consciousness while you are talking to the young man. He has told you that they are relaxing after a stressful week and have injected something and have also taken bars. So that's like if anybody who doesn't work in substance use, that's like a kind of a colloquial term for Xanax, for illicit Xanax, laced with fentanyl, and they washed it down with alcohol. How should you check to see if the young woman has overdose? What should you not bother to check? Oops, I'm sorry. I didn't mean to. I'll go back to that case. I meant to try to get the chat up. So what should you check? And what should you not bother to check? Well, for instance, would you bother taking her heart rate? I get asked this all the time. Would you bother, trying to get a pulse? Does that matter if somebody's not breathing? Yeah, respirations, that's what I would check. Is she breathing? So one of the things is try to not waste time, right, with things that you really don't have to evaluate, which would, number one would be, you really don't have to take a pulse. That's really, if a person's got slower absent breathing, that's, that would be enough. So you determine that she has overdosed. What actions are not advisable to take? Like what are some of the things that you shouldn't do that people talk about all the time? Like what do you think about trying to give her coffee? Yeah, cold shower, that's a bad idea. What about giving her coffee, trying to give her coffee? Do you think that would work? Yeah, no, it wouldn't work. What about injecting, I get asked this, like injecting her with an amphetamine. Would that reverse it? What do you think? So I have one person that says no, that injecting somebody that's in an opioid overdose with an amphetamine wouldn't work. What do you think? If you think about like the receptor stuff, would that work? So here, I actually have a theory. Now there's no way for me to test that, test this theory out, none, mind you. But I have a theory it would make you die faster. Because an amphetamine would actually increase your heart rate, which increases your oxygen consumption. And the one thing you don't get is oxygen during an opioid overdose. So I have a theory that it might actually cause you to overdose faster. So you decide to administer naloxone. How long will the naloxone be effective? So yeah, right, 1 hour to 90 minutes, right, exactly. Is that long enough that you might decide not to call further emergency medical services? So no, great. Yeah, no, this is an automatic trip to the ER. As a police officer, you see drug paraphernalia at the scene. Is the young man at risk of prosecution? So that depends on the state that you're in. In Louisiana, he would not be, because he would have medical amnesty. And so that's to encourage people that are using together to call 911. Unfortunately, in Texas, we don't have medical amnesty. Okay, so here's some myths and facts about naloxone. So have any of you heard this? Availability of naloxone encourages drug use. Have people heard that? I hear that from police officers and DEA agents all the time. Yes, I hear that from DEA agents all the time. So that's like a fundamental misunderstanding of substance use disorder. I mean, that ship has sailed. They're going to use no matter what. That idea that police perpetuate that there's people sitting around bringing each other back with naloxone. Think about what naloxone does. It puts you into withdrawal. Any of you guys that work with people who have substance use, what's the one thing they never want to experience, that they don't want to go through? I mean, do they enjoy going through it? Yeah, withdrawal. To the man, they would do anything to avoid withdrawal, and this puts you into withdrawal. There's no way to regulate it. There's no way to say like, well, I'm just going to take a little bit, enough to keep me breathing. You can't do that. So it's an all or nothing thing. So you're either in withdrawal or you're not. So that actually just doesn't play out. Now, is it true that people will re-overdose and you have to use naloxone again? Yeah, it's a chronic relapsing disease state. And until you address the issues that make that person use in the first place and get them into treatment so that they can sustain recovery, they're going to re-overdose. But they're not abusing naloxone, and there's no. I get asked that all the time too. Like, when do you call it? When do you call it? When do you say like, okay, I'm not gonna use naloxone on this person because this is the third time this week they've overdosed? Well, I don't know. Never. I mean, I'll give up when they're dead, I guess. So we never give up. So every time we bring them back, it's an opportunity to talk to them about getting into treatment. So, and every once in a while that works, that they do get into treatment. But no, there is no 3 strikes and you're out rule or anything like that. Well, what about naloxone being abused? Has anybody heard of that? That it can be abused somehow? Yeah, no. If you think about it, it causes you to, well, it's hard to abuse it. How about, do you think that it can be self-administered? Oh, great. Yeah, no, it can't be. That's right. If you're not, you would be extremely unlikely to do it before you kill your high. If you're actually, still responsive, this would reverse your high entirely. So that is extremely unlikely. So, and you don't feel yourself overdosing. It just happens. Um, so is naloxone useful for all drug overdoses? Your thoughts? No. Okay, I have a good question here. Okay, scenario, someone that overdosed unresponsive on the floor. As you fumble through your naloxone kit while waiting for 911 to arrive on the scene, after you called, you realize your naloxone recently expired. I would use it. And that's a PharmD talking to you. Expired naloxone will still work, and it's better than nothing. I would use it in my capacity as a community, just as somebody trying to help out. I would absolutely use it every day and twice on Sunday. So, so let me tell you a little bit about drug expirations. Drug expirations are the drug manufacturing corporation trying to get you to buy more of that. So all it means is, like, this one expired January of 2019. So all that means is they didn't test the effectivity past that date. That doesn't mean it isn't effective after that date. And the truth is, it's probably effective for like 10 or 11 years after that date. Not 90 to 100% effective. And it would slowly lose effectivity after that. Consider this, like, I run this emergency stockpile for anthrax exposures in College Station. And the FDA just called me on this doxycycline, and they said, like, oh, put another 11 years on that. So that's how much they think. So this is just an arbitrary date that the drug manufacturer puts on there that says, like, okay, we're going to put it out at 2 years. After 2 years, we haven't tested if it's effective after 2 years. But it is effective, especially if it's being stored under really good conditions, like not exposed to heat and light. It's likely that it would almost maintain 90% effectivity for almost forever. So yeah, no, I'd still do it. But that's entirely up to you. But that's not talking, like, would I do that at a hospital that had expired naloxone? No, but I would do it, here in the community. If I stumbled across somebody, I would do it. Naloxone works like a stimulant to reverse an opioid overdose. Is that true? No, it's not true. Perfect. Okay, so there's all the answers to that. I get a lot of questions from first responders and stuff, but we're almost up at our time, right? I think I have till 1 o'clock. What's my time limit here? We went through all the stuff that I needed to go through. Amy, when am I finished? I'm so sorry.
Say it again. I'm sorry.
What's my time limit? I just want to make sure I have enough time.
Oh yeah, so you have about 1 minute.
1 minute. Okay, so we got through everything that we needed to do. Okay, so these are some overdose myths. There's some myths, and I talked to police officers about touching it, that you'll overdose and die from touching a white powder. That's not true. You would have to have a big cut on your hand and, like, do this and lick it. Yeah, so that's actually not true. There was some really interesting cases that were put into the Houston Chronicle a couple summers ago about somebody that a police officer that touched an unidentified white powder and then reacted. Unfortunately, I wasn't there, but he had pounding heart. He had rapid respirations, Does that sound like an opioid overdose? Mm-mm-mm. So that looks like a panic attack, which I would be panicked if I touched something accidentally and didn't know what it was. But that actually, these symptoms down at the bottom, feeling sick, sweaty, pounding heart, dizzy, not nausea, vomitings, they are not symptoms of a fentanyl overdose. These are not symptoms of an opioid overdose at all. So, there's a lot of mythology out there. And what we want to do is be mindful as clinicians and practitioners in the substance use community that we want to make sure that the best information is out there. So, can I expire naloxone? Yes, not ideal, but better than nothing. What if I administer too much? Not possible. Not in nasal sprays, anyway. Where can I obtain naloxone? Community distribution. You can get a prescription from your doctor, or you can use the Louisiana standing order and go purchase one from a pharmacy. So if you want, please take a picture with your phone of this email. If you want to contact me and my team about anything to do with naloxone rescue kits or opioid overdose, please do contact us. What about exposure to carfentanil? So carfentanil is an ultra potent opioid. Is the question like how many doses of naloxone does it take? A lot. Carfentanil is a very ultra potent opioid, and people are quite, oh no, it doesn't react to skin exposure. No, you'd have to have a huge cut or have a rash that was open. You'd have to have some kind of open skin to actually have a person react to that. It's just not designed to be absorbed through the skin like that. You would have to put, do you know what an occlusive dressing is? You'd have to put, take it, put it on there, put ointment on top of it, and then put duct tape on it. And then you could, get a blood level, if that makes sense. So the slides are available through Amy. I sent the slides. So yeah, you can ask Amy for the slides, and you can have them, share them, take our colors off, put your colors on, do whatever you want with them. They're free to use and pass around. All I ask is you give a shout out to the A&M Opioid Task Force, okay? So thanks for listening today, and have a wonderful day, and I hope you can get a hold of a naloxone rescue kit sometime soon. I've actually used mine 8 times. Maybe it's the people I hang out with, huh? 8 times.
Thank you so much, Dr. Alonzo.
Thanks. Have a great day. Take care. Bye.
Bye. Everyone, thank you so much for participating. We will be sending out the kits. We'll just use the address we have on file from you from your registration. That's where we'll be sending the kits. And I guess
they're on their way. They're on their way. Okay, bye.
Bye, thanks.